Hey, can you like click to let me in? It say on my side on my computer that you need to let me in. So I tried it on my iPad.
Yeah, I have to wait until the tech support is doing something in the webinar right now. So I don't really have control over anything right this minute, so we just have to wait until that happens.
Okay.
Okay, but I'll be happy to, I'm gonna take a look at one more thing and see. I've actually reached out to them too. Can you see my slide? No.
No.
Okay. Is anybody else there? Can anybody else see my slides?
No.
Nobody? Okay, let me try something. I thought I shared already, but. Okay. That's better. Okay, how about now? Can anybody see anything?
No, we just see you still.
Okay. I'll try again.
It had it up there the first time when you was on. It said welcome. It was black
Yep.
and white.
Yep. You saw that? The welcomes. You saw the welcome?
Yes, but it's not on there.
How about now?
Nope.
For the Warriors to advance. It's right here.
Check the chat. Yes, class will start soon as we can figure out what's going on. Oh, it looks like. If you guys start to see my slide, let me know, okay?
Okay, I will. I'm paying attention.
Okay. Can anybody see anything now? Here, let's see if anybody can see this slide. Can you guys see this?
Still just you.
Okay.
What's up?
Hello. Okay. Hello.
Can you hear me?
I can hear you.
Thank you. Actually, I just joined to see how it is because I'm brand new. I'm trying to join and to see how it is. I don't even know what the subject of a class is about today, but I'm very interested
Okay,
in participate.
okay,
And I want to subscribe for the membership and use as a resource for my LVN program. I am in California.
okay. This is the RN program.
So yes, I don't know. I should be, yeah, this is the RN program. So I should looking for the LVN, right?
Yep. You should go onto the website and it should help direct you. And if you can't find it that way, it's a little green circle and it says we are here. And if you click on it, you actually get to a person and they'll help direct you.
Okay, thank you so much. I appreciate.
Have a good
Bye-bye.
day.
Bye.
Bye.
Sorry. Hello.
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 Okay.
Yeah. So, sorry for interrupting. I'm here for LPN also, but I asked that same question. They said there's just one topic. I think it was nursing care or something that they said is for RN. Then the LPN, they can still use the same material.
Yep. Yep. Sure. You bet. This is the RN one and we're doing perioperative today. I'm just waiting for things to click over here. So be patient. Okay. I'm going to close this screen for a second and see if you guys can see my slides. Okay.
Okay.
All right.
And I'm here for my RN. I'm scheduled to take
All
my
right.
NCLEX on Saturday morning, so I'm just here to soak up.
All right. Well, good
Wow.
luck to you.
Thank
All right.
you.
Can you guys see my slides?
No.
Okay.
No.
All right. So hang on here a second.
No.
I'm going to close it and try to restart my slides.
Can I ask you a question quick? I'm sorry. What subject gonna be today?
Perioperative and post-operative nursing care.
Oh,
Good.
thank you.
You are welcome. All right. Give me a minute, guys. No. Okay. From beginning. Start at the beginning. It still says. How about now? Anybody see my welcome slide?
No.
No, ma'am.
Let me see if there's anybody in the chat. New. Okay, I'm gonna try this one more time here. It says I cannot share the meeting. Is there anybody on from tech support? I know they were working on something. Yeah. Okay. Oh, that could be. It says I'm not the host. I don't even have a bar. I can't really do anything because it says I'm not the host. And all right, give me a minute here, guys. Try to share one more time. So yeah, it's not allowing me.
Someone It's recording. Looks like this person is host, not you.
It says, we have to join as a participant. Okay. I think we might be, can you see my slides now? Oh. All right, is everybody there?
No, we can't see it.
Yes, but there's nothing we can see.
You can just see me?
Yes, ma'am.
I think that someone joined as a host, so the person need to remove it. So
Yeah,
you now
it
gonna
looks
be
like
able
somebody
to.
is still the host,
Yes,
and I know
some
our technical
student
team
join
was working,
as
but
a host compared to
um,
be as a participant. That's why.
so are you able to check to see everybody who joined? Can you please make sure that you are
Everybody can just check if you can share, because when you click on share, it's only the host that can share. So if you click on share and you are able to share, it means that you join as a host. You have to
yeah,
log out.
I can't share. It says that
And the person who joined as a host has the
yes.
microphone mute. Because on the list of participants, you can see who is the host.
Yeah, so okay. So prep should be me. Host should be me. Oh, there's
I may have to get out of it and come back in.
okay. Okay. Can you guys see me?
We can see you, but not the
No slides yet?
slides yet.
Okay. So somebody's still
Somebody still as a host and recording as well.
I'm so
But not you. You talking. You are not host. Like someone else is host.
Okay. So I'm participant, so I'm not sure.
okay. Then you're good. Then you're good. I'm gonna try to go back here. Yeah, I can't, if I end the meeting's over, so I can't end the meeting.
I think you had shared the slide before the lady started speaking to you concerning the LPN.
Okay. All right. There you go. Can you guys see that?
Yes.
Yes.
Okay.
Yes.
All right. So I think we're good now. Whoever, it could have been my tech team too. So no worries. We are a little bit behind, but you guys can hear me, you can see me, and you can see my slides, right?
Yes.
Yes.
All right. Well, I apologize for the technical difficulties on our
No
end.
worries.
Thank you all for being here. I think we'll get through it a little bit quicker anyway tonight. So I just want to say welcome everybody. Thank you for your patience this evening. And I'm looking forward to sharing this presentation with you. So are you guys all ready? Let's go. First, I want to just say a couple of things. Welcome to the session. I hope everyone is doing well. Sorry again for the delay. Thank you for my technical team for making these things happen and repair them and fix them and get us moving. Quick thank you to Fermones, who's manning the chat. If you have questions, please go ahead, put them in the chat. I also love to hear what you have to say. I'm going to move a little bit quicker because A, we're a little bit behind, and B, there's another class, so I want to make sure we don't overlap because then we do have technical issues. Also, I want to say I know there were people in my last couple of classes last week who were getting very close to taking their board. So I just want to wish you well and give you a pat on the back and say you can do this. and wish you the best of luck. Not that you're going to need any luck because you guys are really, really sharp students. In fact, I was just telling my my boss that the other day. All right, sending you all good vibes and let's get going.
Yeah, I have a question, Professor. Not a question, request. There
Yeah, go.
are some people they're waiting to get in.
Oh,
They cannot get in, so they are like waiting.
okay. I do not see the button that says I can let them in.
Oh my.
Hang on, let me look here. Nope, there is no option for me to do that.
No, your session already fully booked. That's why no one can enter now. That's
Oh,
saying to
well,
us.
oh, because they filled the slots and even though there's
Right,
51
exactly.
people here, that's why. Okay. All right, so there's the answer to that question, right?
So the session is full?
Well, see what happens is people sign up for it
Yeah.
and it fills in the spots and I don't have control over that. That's all done on the website. So if you sign up for it, there's one less spot and it must have been pretty full. And it looks like that's why they can't get in because I have no option to allow somebody in.
No, but it says we have a 39 slot remaining.
Yeah, I'm not really sure why then I can't answer that. Is somebody here in the technical team that can address that? I'm gonna, oh, somebody already put that in there. Okay, I see it. There's, okay, are you there, everybody? All right, we're gonna get going. Sorry that there's people still in the waiting room. Hopefully that the person in the tech support can answer those questions and let people in. Because I only see 51 participants. So. Actually, I'm going to go ahead. Give me one more minute. I'm going to reach out to my technical team on another way and see what they can muster up here. So just give me one more minute. Just send them a message. Okay. All right. Well, I'll keep checking. I just want to check one more time here before I get going. All right. Nope, nothing in there yet. So, all right, guys, we're going to get going. I'm sorry to everybody who can't get in and is stuck in the waiting room. Hopefully, we can figure out how to get them in. Again, I know there was a little technical thing, so I'm not sure exactly what that was. But here we go. Is everybody still there?
Yes.
Yes.
Okay. All right. Key concepts to preoperative and postoperative nursing care. Essential strategies for optimal patient outcomes. In this guide, we'll first explore preoperative care and then arrival in the operating room. We'll talk about postoperative care, some postoperative complications, one-day stay surgical units, some postoperative teaching methods, and support for your NCLEX exam. And what you're all probably most excited about is doing some practice questions. Preoperative care is crucial for ensuring patient safety and readiness for surgery. This section covers essential practices and considerations to optimize patient outcomes during surgical procedures. Okay. Informed consent is a legal and ethical requirement in surgical procedures. It involves providing patients with comprehensive information about the surgery, risks, benefits, and alternative options, ensuring they can make educated decisions about their care. So you'll notice in the presentation, I put things in red. Hopefully you can see that. Those are the things I found to be like the most important things to kind of take away with. Y'all just got out of nursing school, so you don't need a lecture. I'm just kind of reviewing key things that I think are important and you may run into on your NCLEX, and you're definitely going to need to know in your practice, especially early on. So the parts in red are those things that I think are important to walk away with. So legal requirement. Informed consent is a mandatory legal requirement before performing any surgical procedure, ensuring patient rights are upheld. Depending on the surgery type, orthopedics, for example, will have the site of the surgery signed by the MD. I don't know if anybody's works on in a surgery department where they do a lot of orthopedics, and if your surgeons actually go in and sign whichever, you know, the left knee or the right knee or the hips, they'll actually put their signature on it to avoid doing the wrong thing. So comprehensive information. Patients must receive detailed information about their surgery. It must include the risks, benefits, and alternatives and to make informed choices. The provider performing the procedure must explain these things and answer any and all questions about the procedure. Nurses can witness the patient signing and giving consent, and what you're signing to is that the patient is signing without coercion and that they are well informed and capable of signing their consent. Informed consent empowers patients to participate in their health care. Has anybody been able to do this? Go ahead and unmute and share. If not, I'll keep right on going. Informed consent in emergencies. Emergency situations may prevent patient communication. Healthcare providers must act in the patient's best interest. Using implied consent when immediate action is required. They should attempt to reach a surrogate family member to obtain consent if it is appropriate, but in an emergency, sometimes that is not possible, and we have to proceed with the patient's best interest. Document the rationale for the decisions that were made. If you happen to be a witness to these things, you should certainly be documenting them as well. But this is really about providers who are going to do procedures as well to be documenting. And the family or patient or surrogate, however you want to look at that, should be notified as quickly as possible after the procedure is completed. And then always, always, always follow institutional protocols for emergency procedures. Nutrition plays a vital role in a patient's recovery. Preoperative dietary considerations include ensuring adequate protein intake, managing diabetes, and understanding fasting guidelines to reduce the risk of complications during surgery. Nutrition, we kind of talked about that. It impacts healing and overall health outcomes. Is somebody on, can somebody put that on mute if they're talking? If you have a question, that's fine. I'm happy to have you share, but it sounds like there's some other noise out there. Are you guys hearing that too? Okay, thank you. Now we have music. Can somebody mute that, please?
Professor, is it possible for you to mute the person?
And mute it. We'll do the best.
We're still hearing music out there, somebody.
Yeah, because I'm sure he doesn't know he's being heard.
All right. All right, I think we're good now. Diabetes management. So managing diabetes is vital when you're going to have surgery, right? Usually when surgeons are having patients scheduled and they know that they're diabetic, they'll try to put them in the priority of early surgical times. That can't always happen, but it does happen as often as it can. And then the primary care physicians, the people who are doing their pre-op history and physical, will usually tell the patients exactly what it is for medication they're supposed to take, when they're supposed to take their insulin in the morning, how much they're supposed to take. They really set those guidelines. It's not the surgeon who sets those guidelines. It's the physician who does their history and physical. So let's see. Understanding and adhering fasting guidelines can help reduce surgical risks and improve outcomes. NPO after midnight is the default protocol used by most facilities. However, there are new guidelines out there, and I'd like to hear from you guys about that. For fluids up to 2 hours before surgery. Know your institution and your surgeon's guideline because they may differ. What are your institutions doing? Do any of you work in the surgery department where you can share something about that? Mine still does NPO after midnight. Anybody have anything they want to share? It's always easier if you unmute instead of putting it in the chat for me when I ask questions like that. All right. Like I said, at my hospital, they're still doing the NPO after midnight. I know that there are some other, I think a friend of mine was in Florida and they had the 2-hour thing. So that was really kind of surprising to me. Okay, moving on. Proper elimination and bowel preparation are important to minimize the risk of infection and facilitate surgical access. Nurses must assess bowel habits and educate patients on necessary preoperative procedures. Some procedures require bowel prep. Verify that the patient has completed it correctly and what the results were, and they would both need to be documented. Make sure that you're aware of what your hospital and your physician guidelines are. Again, they can differ. And of course, alerting the MD if the prep was not done or the results that the patient shared with you are not as they are expected. Okay, surgical site preparation includes cleansing the area to reduce infection risk. Client teaching involves explaining the procedure, recovery expectations, and answering any questions that you can answer to alleviate anxiety. One thing I do want to mention is if you happen to be at the bedside with a patient and they do their consent and then it's almost time for them to go back, or while you're waiting, they come up with more questions and you can see that there are things that have gone unanswered or they're still unsure. Don't hesitate to reach out to the physician or the anesthesiologist, depending on what it is they're concerned about, and have them come back and explain. If it's in regards to the surgery itself, however, it really does have to be the surgeon. So I meant to say that earlier, but I just wanted to throw that out there. Cleansing the surgical site. So proper surgical site preparation includes a thorough cleansing to significantly reduce the risk of infection. Verify patient completed the shower prep like a HIPAA shower and that they refrain from shaving. Follow surgeon and hospital specific procedures. I know that in open heart surgery back in the day, we used to use clippers when patients were going to have open heart. We didn't want them shaving at any point. We wanted them to just do their HIPAA shower, and we had them wash with, they were similar to a HIPAA. They were wipes that they had to use in the area where they, like on their chest for open heart surgery, that would help decrease the bacteria. Client education. Preoperative client teaching is essential for explaining the procedure and addressing concerns to help alleviate anxiety. Let patients know that they will have discharge teaching before going home to ease their anxiety so they don't feel like they have to try to remember everything you're telling them. And it's important to recognize when patients are in a good place to hear teaching information. Anxiety pre-op may inhibit learning, so keep things pretty straightforward and only necessary. Informing clients about recovery expectations is crucial for their understanding and their peace of mind. Explain possible timeframes for the procedure and the recovery room. And if they have they're going to have a catheter, if they're going to have drains. I say that lightly, though. Make sure you are very straightforward and only tell them necessary things. I'm not saying to leave things out by any means. But if you have a patient who's highly anxious, you're probably not going to want to go into tons and tons of detail about things, obviously, unless they ask a specific question. Okay. Understanding the psychosocial aspects of surgery is essential as well. Providing support and addressing fears and concerns can significantly enhance a patient's readiness and satisfaction. Answer questions and be supportive. If questions require the MD to answer, make sure you get that MD so that the patients feel confident and well-informed when they undergo their procedure. Also explain to the family and their support system that are waiting there for them to give them a chance to say their goodbyes. I don't like to say the goodbye. I like to say just so long for now. Okay, a preoperative checklist is a critical tool for ensuring that all necessary preparations are completed. This includes confirming patient identity, support person accompanying them, verifying consent, assessing vital signs, going through their medications and their allergies. Latex allergies are important and require special equipment in the operating room. So make sure that you verify that the patient does not have a latex allergy once again, but hopefully this has been addressed many times before you get to the point when they're going to go off to surgery. But nonetheless, it is important to reiterate. Latex allergies can be associated with allergies to things like kiwi, banana, avocados. So if this happens to end up identified in your verification time with the patient, make sure you're letting the physician know. That's really important as well. So the things in red here, I'm just going to kind of briefly look at this slide with you. Verifying patient identity is crucial to ensure the correct procedure. I can't imagine somebody would want to go in and pretend there's somebody else to have a procedure, but you know, who knows? Correct procedures performed on the right individual and check their wristband again to make sure they have the right wristband on. Verify consent, make sure that we have informed consent because it is vital ethically and legally. And that make sure you have a set of patient vital signs. That's usually part of the whole checklist, that we have a set of vital signs before they go off to surgery. A thorough review of the patient's medications again, and allergies, especially if they have a latex allergy, and verify the compliance with their medications, that they took what they were supposed to and they held what they were supposed to, and confirm that they do not have that allergy to latex. And make sure you verify the time they ate last and that when they had fluids last. They're usually all part of that the pre-op checklist that the nurses do. So preoperative medications can include sedatives, antibiotics, and analgesics. Understanding their purpose and administration is vital for reducing anxiety, preventing infection, and managing pain. When addressing pain management, it is a good idea to ask what has worked for them in the past. What did they have success with? And not only that, they will probably readily tell you what they didn't have success with. So making sure you relay that information both to the physician, the surgeon, and to the anesthesiologist. I always found it helpful too to ask patients early on when we were initially going through things, if they've ever had surgery before, have they had anesthesia before? If the patient's having general anesthesia versus like spinal anesthesia, making sure that they didn't have any problems with it. And if they tell you that they had problems, like they woke up in the recovery room and they were vomiting, make sure you let the anesthesiologist know. They usually come and interview the patients anyway, but sometimes patients get nervous and they forget to share those things with the physician, but they tell their nurse literally everything. So you're going to want to share those things, because a lot of times in surgery, the anesthesiologist can give medications that will make it less likely that they'll get sick when they wake up from their anesthesia. Let's see. I think that was covering that one. All right, arriving in the operating room. Understanding what to expect upon arrival in the operating room can help reduce patient anxiety. This section covers environment, personnel, processes involved in the preparing for surgery. Sometimes amnesics can be given to patients who don't want to remember their trip to the operating room. And if you have a patient who's really nervous and they're telling you that, again, this is one of those times you're going to want to talk to the anesthesiologist about that, because the patient will tell the nurse, but they don't always remember to tell the anesthesiologist. Patients may encounter various equipment, staff, and protocols upon entering the operating room. Providing a description of the environment can help demystify experience and reassure them. Make sure you tell them who they're going to see in the operating room, that they're going to see their anesthesiologist that they hopefully met and did an interview while they were in day surgery or while they were waiting. Tables full of instruments, tell them it'll be cold in the operating room, but that they'll put blankets on. Staff will be in the operating room. Staff will be in there to help them get into the, off of their bed and onto the table, and that they'll get them warm blankets and they'll get them as comfortable as possible. Let them know that there'll be like a circulating nurse and usually the nurse who comes to get the patients will tell them, I'm going to be with you throughout your surgery. So they have an idea who that is, but let them know they're going to be there. And the surgeon sometimes the surgeon's already in there because they've already done their scrub in, but sometimes they're not there. So to help decrease anxiety, let them know the surgeon does have to scrub in and then they get gowned up. And sometimes they come in a little bit after getting the patient settled into the recovery room. I'm guessing a lot of this is stuff you guys probably already know, but some of the key points are the things I want to make sure that you walk away with. The operating room typically includes surgeons, anesthesiologists, nurses, technicians, and each person plays a critical role in ensuring the patient's safety. So nurses support, obviously, the circulating nurse and the scrub nurse. The circulating nurse will be the one talking to the patient initially before they have their anesthesia and explaining those sorts of things, providing support to the surgical team as well and to the tech and the surgeon. This talks about the roles and the responsibilities of the people in the operating room. A brief description of what happens in the operating room. Patient monitoring. Monitoring is the critical step in the operating room to ensure patient safety. Anesthesia administration will be delivered by the anesthesiologist to ensure patients remain pain-free during surgery. Surgical procedures performed by the surgeons and medical professionals, the nurses. And usually sometimes they'll have two surgeons, sometimes they'll have a physician's assistant. Just depends on what kind of surgery is being performed. The other piece that is important about what happens in the operating room, and this is something that you may end up coming across, is that in the operating room, they do a timeout procedure, and literally everything stops in the operating room, and they call it the timeout procedure, and it actually starts, this is a procedure done prior to starting surgery to verify correct patient, correct procedure, and correct site. It must be documented in the surgical record. Postoperative care is essential for monitoring patient recovery and managing complications that may arise after surgery. This section highlights key nursing responsibilities. Monitoring respiratory and cardiovascular systems is critical in the postoperative phase. Nurses must assess vital signs, oxygen saturation, and any signs of distress to ensure patient stability. What other things do we do in post-op to help keep patients safe and well? We do TED hose, compression hose, sequential compression devices, ice machines for total joint patients. Sometimes I've still seen surgeons doing CPMs, which are continuous passive motion for people who have total knees done. Medication pumps, drains, Foley catheters. We do lots of things to monitor and keep our patients safe. If there's anything I've forgotten and you guys want to go ahead and unmute and share, please feel free. I'm going to just quick go through the red in this slide though. Assessing vital signs. I know you all know that, including heart rate, blood pressure to detect any potential issues. Respiratory rate is probably one of the most important things to monitor. Obviously, airway and respiratory are like key things that you need to remember. Monitoring oxygen saturation is crucial for ensuring adequate respiratory function and preventing hypoxia. And be vigilant for any signs of distress in patients, indicating the need for immediate intervention. One of those signs can be restlessness. It can be super simple, but restlessness can be an indicator that attention is needed. Something's awry. So if you have a patient coming out of the operating room and suddenly they get restless, check the airway, check oxygenation. Something is awry. So check your patient out. Fluid and electrolyte balance. Maintaining fluid and electrolyte balance is vital for recovery. Nurses should monitor input and output very, very carefully, recognizing signs of imbalance and addressing them promptly. So here, I think it's important to remember to monitor input and output. You meticulously monitor fluid, monitor those I's and O's. Check to see how much fluid was given in surgery. Make sure you know that. Did your patient receive any blood transfusions in surgery? All those things are going to be documented on the OR record, and usually they're given in verbal report from the circulating nurse to the recovery nurse. But these are things that are important to you taking care of the patient because they can all affect obviously you're going to have more output under those circumstances. Did they end up getting more fluids? All must be considered to have an accurate I and O balance, and you need to monitor that closely. And then checking for signs of imbalance. Quickly recognizing electrolyte imbalance is important. Checking the patient's skin turgor, their mucous membranes, again, their output. Checking sodium and potassium and bicarb will also be important. Obviously, those will come a little bit later once they do the labs, but those are things that would be important if you start to see any of those symptoms like the skin turgor and the mucous membranes or decreased output. Or their restlessness. If you see the restlessness and you can't put your finger on what's going on, they may need to draw some labs because maybe something is off. Common fluid and electrolyte imbalances include dehydration and electrolyte disturbances. Understanding these conditions and their treatments is essential. Fluid balance can occur postoperatively. We get patients who get dehydrated, which can cause hypernatremia, affecting an overall recovery. Hyponatremia can also be caused because of excessive fluids. Hyperkalemia can occur due to medications and due to poor kidney function. So it might be helpful to know that patient's record before they have surgery or, when you're taking care of them. It may be of importance to know, oh boy, this patient has, poor kidney function. So we really need to watch a little closer. Electrolyte disturbances can lead to serious complications, and postoperative care, understanding and treating fluid and electrolyte imbalances is essential. So understanding hyponatremia and hyperkalemia. Hyponatremia is characterized by low sodium levels in the blood. You know that. It's less than 135. Common symptoms include confusion, headache, fatigue. Hyperkalemia involves elevated potassium, and symptoms include muscle weakness and palpitations, and obviously both of them can lead to very serious complications. Let's talk a little bit about some postoperative complications, which are crucial to recognize for patient safety. Nurses should be vigilant for signs of complications such as infection, bleeding, and respiratory distress. Early detection and intervention can significantly improve patient outcomes. Remember, patients tend not to take deep breaths postoperative due to pain. So you got to keep an eye and you got to keep encouraging patients. Another thing that they can cause, which I'm sure you're all very well aware of, is pneumonia as we move down the process, right? If they're not taking deep breaths because they had surgery and it hurts to take a deep breath, now we get fluids that accumulate. They're not coughing like they should. They're not taking a good deep breath. It all potentiates and turns into a potential case of pneumonia. So on this slide, things that you may observe: signs of infection, you should watch for redness, swelling, fever, anything that might indicate a fever. Check their site. Indicators of bleeding. Look for bleeding, including unusual bruising, blood in the urine, or other bloody fluids. Check drains. Make sure that it's not filling too fast. Incision sites for bleeding. Respiratory distress signs. Nurses should monitor for rapid breathing, shortness of breath, confusion, wheezing, that cyanosis, suddenly kind of taking that blue or that gray look, or when you look at a patient and you can see the color literally just draining right out of their face. Those are all potential signs that there's a situation going on, especially respiratory distress. We're going to talk a little bit about dressing changes. Proper wound care is essential for preventing infection. Nurses must be proficient in sterile dressing changes and wound irrigation to facilitate healing and monitor for complications. And that's pretty much what all of this stuff says. But I always like to make sure you have a slide that talks just a little bit about what it is we're discussing. Proper wound care is vital for preventing infection. You know that. Nurses must perform sterile dressing changes to maintain cleanliness and prevent infection and the healing process. Effective wound irrigation techniques are essential for cleaning wounds and removing debris and aiding in recovery. That's what wound irrigation is really important for. Cleaning the wound, removing debris, and aiding in recovery of that wound. So this is a very generic slide for sterile dressing. There are all kinds of different things out there about sterile dressing changes. There's 13 steps, there's 8 steps, there's 9 steps. Follow your hospital's protocol and what your procedures are. So these are very basic. Gather all your supplies, perform hand hygiene thoroughly, put on your sterile gloves to maintain sterile field, remove the old dressing carefully, avoiding contamination. Don't reach across your field. Don't let anybody else reach across your field. You know, do the wound cleansing if that's what you have to do. Depending what kind of wound you're dealing with here, obviously. That's why I had to make this kind of generic because depending on the type of wound that you're dealing with, it changes some of the aspects of the dressing change, but maintaining sterility is key. Then, of course, apply the new sterile dressing and follow your protocol for how often you are supposed to change them. A lot of times wound care gets involved and makes recommendations as to what medications you should be using, or even a surgeon or their physician at the bedside, a hospitalist or what have you. A lot of times they'll say, you know, this should be done twice a day or what have you. It should be irrigated, you know, every day. We should be applying this, make sure there's sterile dressing. So make sure you're following whatever kind of recommendations or orders that you have based on the type of wound that you have. And I guess the other thing I would encourage you to do is if you've never done it, wound irrigation, make sure you ask to do it with someone so that you kind of get the hang of it. Because it does take a little bit of practice and technique in order to do it well. So this is another basic slide about wound irrigation, again, because the types of wound change how you do wound irrigation. So these are basic steps. There will be other things added to that depending on the type of wound. Wound irrigation is important for cleansing wounds. It helps remove debris, bacteria, dead tissue, wound exudate. Hello, somebody's not on mute. Sorry, thank you. Dressing residue and topical medications. Hello? I'm going to start over just to make sure you guys heard all that. Removing debris, bacteria, dead tissue, wound exudate, dressing residue, and topical medications. So if you are putting medications on a wound, when you go to change it the next time, do another sterile dressing change, this wound irrigation will help remove all of that medication that was there previously. Proper irrigation technique prevents infection. Pressure is key. That's why I said if you've never done it and you have to do it for a patient, make sure that you have somebody with you that has done it, because the technique is really important. You don't want to do it too hard. You don't want to do it too soft. You want to do it just the right amount of pressure so that you are removing the bacteria and the debris and the dead tissue and all the other things that need to be removed. You want to cleanse the wound just enough not to harm the tissue. It should be irrigated from the cleanest to the dirtiest, and use sterile saline or appropriate solution for irrigation. Again, this is where it comes in where you'll either use saline, but you'll also have direction if there's something else that they're recommending be used to cleanse a wound. And irrigation obviously should be done before dressing changes. Ambulatory care. Ambulatory care includes follow-up visits and at-home care strategies that you'll discuss at these ambulatory care procedure places, and patients post-surgery. Understanding the procedures and providing clear instructions ensures successful recovery. These centers are patient-centered. They do not have the capability to admit patients overnight. Urgent care and walk-in care clinics here are examples of ambulatory care. They allow for follow-up visits that are crucial for monitoring any kind of recovery or complications after surgery. They talk very much about at-home care strategies. They're personalized and to ensure a smooth recovery process when the patient is discharged, because again, these patients don't get admitted overnight. And they do a lot. When they say patient-centered care, they talk a lot about patient education as far as the recovery process and what to do post-operatively to have successful outcomes. In some ways, they're very similar to one-day stay units, but they're more of visits as opposed to units where they actually do a surgery. One-day stay surgical units are designed for procedures requiring short-term hospitalization. We have places here that actually do total knees and hips, and they come in, they're outpatient procedures, they have their procedure. I said hips. Last I checked, they weren't doing hips, they were just doing knees, so I apologize for that. But when you have a total knee done, they'll have their surgery, and then they'll have their 4 hours of recovery. They get up with therapy, make sure their pain is managed, and then they get discharged home, which is still shocking to me, but it does happen. Common procedures in one-day stay units include laparoscopic surgeries, endoscopic surgeries or procedures, minor orthopedic surgeries, although total knees I would not call a minor surgery, allowing for quick recovery and discharge. And I have seen many more total joint replacement places pop up at various places in the United States. Management of patient complications. So effective management of patient complications in a one-day unit involves early detection, appropriate intervention, and patient education to ensure safe recovery at home. The thing about complications in this particular instance in same-day surgery units is you're supposed to teach patients when they're at the optimal learning time. Unfortunately, there's not a ton of time when it comes to patients who go to these same-day outpatients and they're going to be discharged shortly after their procedure. So you have to pick the best opportunity to teach the patients that you can. And if they have caregivers or loved ones with them that you can also include in the teaching, that is also helpful. So you have to be really prudent about how and when you pick and choose to teach your patients about things. Make sure they've had their pain medication, make sure they are comfortable, and that they're as optimal as they can be under their circumstances of being in a same-day setting to teach them as much as you possibly can. So patients at higher risk may not be suitable for outpatient surgery centers and should be identified prior to being scheduled, obviously. A physician doing the pre-op and their history and physical would be the person to identify a high-risk patient and maybe say, nope, definitely not a same-day outpatient setting appropriate patient here. Another person would be the anesthesiologist reviewing the case. They may also identify that a patient would be not suitable to go to a same-day setting. If you're the nurse caring for that patient and you identify something, let the provider know as soon as possible. Transferring to an inpatient facility or an observation unit it has happened, and sometimes it's necessary. So let them know, and then if they have to be transferred, they have to be transferred. But that's really how we handle that. Anything here I want to share? I didn't make any of it red because I think some of it is, it's things you know. Postoperative teaching methods is essential for empowering patients in their self-care. This section will explore teaching methods to enhance patient understanding and compliance. I think a lot of the key is making sure you teach them at an optimal time. So utilizing strategies such as teach-back methods, written instructions, and follow-up calls ensure patients are well informed and able to manage their postoperative care effectively. I only put the titles in red, but these are important. Teach-back method is really helpful with patients. At least I have found it very helpful. It is one of those gold standard things that they use pretty much across the board as far as educating our patients to make sure, have them repeat the information back to you. Ask them questions that require them to answer you in such a way that shows that they understood what you shared with them. Providing written instructions, I think, is also really important. It reinforces the learning that you've just done with them, and it allows them to refer back to it once they get home. And I have found that patients really do refer back to that, those written instructions afterwards. The other thing is follow-up phone calls, and more organizations are doing follow-up calls where, and even online apps now that you can respond to questions, and then if a response is such that it requires an additional follow-up, yeah, they'll get a call from a nurse too. It does help to answer questions, clarify instructions, and make sure that the patient's understanding is adequate. Just some more about teaching methods. Using clear, concise communication is very helpful, especially concerning surgical procedures. Use simple language. Verify the patient's ready for learning. Use visual aids, especially this works great with kids and even sometimes the elderly, making sure it makes the information easier to grasp. Encouraging questions. Teach-back methods are helpful in determining what your patient understands, so encourage them to ask questions. Your question would be first, and then making sure that they provide a response that shows you that they understood the information, but always ask them if they have any additional questions. And here again, I always encourage family members and caregivers or whoever their loved ones are that are with them to do the same. Wow. Okay, so we talked about the importance of nursing care. Preoperatively and postoperatively, it's vital for ensuring our patients remain safe, and mastering these concepts and skills can provide you exceptional care and support for your patients. All right, how's everybody doing? This section, good? This section outlines resources and strategy for preparing you for taking your NCLEX exam. I pretty much talk about this every time we do a presentation just to make sure that you're practicing, you're setting time aside for yourself to study if you can, a quiet place. Make sure that you're practicing the questions. It helps build your confidence and reinforces the knowledge that you have already. All right, question number 1. I did not run through all of the strategies. But, you know, you can use process of elimination. You can use your ABCs. In fact, I kind of always start with that in my mind when I'm looking at questions to see if it's that type of a question. Prioritization, Maslow's hierarchy of needs, all of those things when you are addressing questions. Okay. Does anybody want to go ahead and read this question? You guys have been really quiet tonight.
Okay, I'll try.
You can do it. I know you can.
A nurse is caring for a client who becomes restless 1 hour post-operative. Which of the following interventions should the nurse implement first? A nurse is caring for a client who becomes restless 1 hour post-operative. Which of the following interventions should the nurse implement first? A. Administer sedatives. B. Administer oxygen. C. Check vital signs. D. Notify the healthcare provider. I think I'll go for assessment first.
I'm sorry, which one did you say?
I'm saying that I'll choose an answer that would cover assessments, which is the vital signs. So I'll go for C.
Okay, C, that's right. Very good. So I just want to point out in the question, very good job reading the question. Thank you very much for doing that. You did great. The key in these kinds of questions when you see them, first of all, it's looking for an intervention, right? It's a key word in the sentence, in the question. So look for those when you're looking at your questions, when you're taking your test. Make sure you know what the question is asking, and it is also telling you that it wants something that you should do first. So it's a priority, right? And a lot of times when you see those words like first and what's the nurse's priority, most of the options are correct, but one is the most correct. One is going to make the most difference in whatever's going on in your situation. And here we know what's going on is that this patient is restless, right? Okay, so we're going to check vital signs. Very good. So I'm going to, I think I actually, let me check something here. I think I actually put the rationales on there. Great. So restlessness is the immediate post-operative period can be due to various underlying causes. Pain would be pretty obvious, right? Hypoxia, hemodynamic change, or hypotension or bleeding. So quick and accurate assessment is important to address the underlying issues. Vital signs help determine the underlying cause of the restlessness. Rationale for incorrect answers. I always like to look and go through those just because I think they give you an understanding of why the answers are not correct, but they may give you insight into future questions. Administering sedatives would mask symptoms and delay addressing the problem, so that's why we wouldn't do that. Administering oxygen without assessing could create a delay in identifying the potential issue. Especially if it were hypotension or tachycardia. And before notifying the healthcare provider, as always, we need to gather information, right? Because what's the first thing they're going to ask us when we call them? Dr. Joe, the patient is restless. Well, Mary, what did you do about it? There you go. Well, hang on a second. I got to go check the patient. That was kind of a joke, but you know what I'm saying. Okay. Does anybody want to read number 2?
A nurse in the surgical unit receives a client who has just arrived from the post-anesthesia care unit, PACU, following an elaboratory laparotomy. What action should the nurse implement first? A, take vital signs and compare them with perioperative measurements. B, assess the surgical site for bleeding. C, check tube or drains for patency. D, assess the respiratory status.
Give you guys a couple minutes to look at this. So this is another one of those, what do we do first? So most of them are correct, but one is the most correct.
I think that D is the answer because we have to check the respiratory status to make sure that everything is going well with the patient.
That's absolutely correct. So when you receive a patient from the recovery room or what have you, always check in respiratory status and airway patency if it's, you know, somebody who's comatose, what have you. So yes, let me go to the next. D is the correct answer. Assess the respiratory status because airway patency, adequate ventilation, and oxygenation are critical to prevent respiratory compromise. I think in the top where it says immediate assessment, sequential assessment, after ensuring respiratory stability, the nurse should assess the other parameters. So that's important to know. I'm going to look at the incorrect answers now. So taking vital signs and comparing with preoperative measurements are important to assess, but assessing respiratory status always takes key priority. And assessing the surgical site for bleeding is important, but the only priority, it is only the priority if there are obvious signs of bleeding or hemorrhage. Respiratory and cardiovascular stability will always be first. Checking tubes or drains for patency is crucial, especially if they are essential for postoperative care. However, respiratory function is the most or more urgent upon arrival from the post-anesthesia care unit. So good job, and thank you for reading. Great job.
I have a question, please.
Yes, go right ahead.
So the question we just, the number 2 question, for instance, if we have, instead of this A that says take vital signs and compare them with the preoperative measures, say we just have take vital signs.
Mm-hmm.
Do we pick that because it's an umbrella term? Because if we take the vital sign, then we'll also be assessing the respiratory status.
So I'm going to say the answer to that. I can only tell you what my interpretation of the correct answer would be, okay?
Mm-hmm.
I would say you would not pick that because if you said take vital signs, how do we know you're going to assess the respiratory rate first?
Okay.
As opposed to the blood pressure and the pulse.
Mm-hmm.
Now, I mean, we would think one would do that, right? But this D says to assess the respiratory status, so it makes it more right, in my opinion. Does that make sense?
Yes, thank you.
You are very welcome. I was going to look and see if it indicated anything in our rationales as to why, if that kind of addressed your question, but it really does not. So, okay. All right. Does anybody want to take a shot at number 3?
Okay. A client who is 45 minutes post-operative begins to experience sudden onset of chest pain and dyspnea. What is the priority nursing action? A client who is 45 minutes post-operative begins to experience sudden onset of chest pain and dyspnea. What is the priority nursing action? A. Administer morphine as prescribed. I'll eliminate that answer because it is important, but that's not the priority. Elevate the head of the bed. Okay, let me read. And then C says obtain a stat ECG. That's also important, but it won't be the priority at that moment. And then administer oxygen via nasal cannula. Okay, so I'll go for answer B, elevating the head of the bed, because that's first, that's less invasive, and that will also help the patient's lung expansion. It could also help with that. So I'll do that first, then I'll do others as well.
Very
So
good.
my answer is B.
Number 3 is B. And I always like to point out, so this is the priority, right? So all of them are right, but what's the most right? And a lot of time, whenever they have the elevate the head of the bed, they always have administer oxygen as an option. So looking at them both, sure, they're both incredibly important, but putting the oxygen on first, the patient still cannot take the deep breath. So putting the head of the bed up, then putting the oxygen allows them to take a deeper breath with the oxygen on. If you kind of think about it that way, it sort of makes sense as to why you'd put the head of the bed up, right?
Yes, please.
Okay. Here's the rationales. So elevating the head of the bed can help improve respiratory mechanics and oxygenation by reducing the pressure on the diaphragm, promoting lung expansion. So it is the first step before administering the oxygen. So you did a great job there. Let's take a look at the incorrect answers. Just sometimes, like I said, the rationals are very helpful. Administering morphine as prescribed alleviates chest pain and reduce anxiety, but does not address the immediate need for oxygenation. It should not be the first priority without addressing the potential underlying cause of the symptoms. And then C, obtaining a stat EKG is crucial to diagnose potential cardiac issues. However, it should follow immediate interventions such as adequate oxygenation. Applying the oxygen ensures the client is receiving sufficient oxygen is critical before conducting further diagnostic tests or administering medications. All right. Great job. Well done. Thank you for reading. You did a great job.
Excuse me, ma'am. Can you bring the question back, the explanation
Rationales?
for 3 back? Yeah. I just have for the D, they said ensure that the client is receiving sufficient oxygen is critical before conducting further diagnostic
Diagnostic
tests.
tests.
So what they mean there is the first thing that is priority to do is to elevate the bed. So elevate the head of the bed. If the patient has shortness of breath, that is the first priority to do. So after that, that is when you can now administer oxygen, right? Or give oxygen, then you can now do the necessary tests or medication, if I'm right.
So B and D are like your priorities, right? Here, let me go back this way. So B and D, elevating the head of the bed, and then oxygen. Because if you think about, if I'm understanding what your question is, or where you were going with that, it was, do we do oxygen or do we put the head of the bed up? Is that right?
Yeah, that's right.
Okay. Putting the head of the bed up allows the respiratory, how did they phrase that? I really liked how they phrased that. Respiratory mechanics of the body and the lungs takes the pressure off the diaphragm, and it allows the respiratory mechanics and muscles to improve oxygenation just by not putting the pressure on the diaphragm. Then you put the oxygen on, and now they're taking a better breath with the oxygen on. Is that where you were going with that? I just want to make sure we're on the same page.
Yes, thank you.
You're welcome. Okay. Anybody want to try to read or do number 4? Not try, because you're very successful, but.
A registered nurse is educating a student nurse about their responsibilities in the informed consent process. Which of the following actions are within the nurse's responsibilities? Select all that apply. Ensure the client understands the procedure, witnessing the client's signature on the consent form, explaining the risk and benefits of the procedure to the client, confirming that the client voluntarily agreed to the procedure, answering questions about alternative treatments and their risks, documenting the client's questions and concerns, and notify the healthcare provider if needed. For this one, I can go the B. B and
I'll give you a hint. There's 3 of them.
Yeah, it's a D and F, because A and C and E, that is the doctor's responsibilities.
Very good. Excellent. My God, you guys are rock stars. Okay, let's look at the rationales, but you nailed it. Witnessing the client's signature on consent form, RNs can witness the client's signature, confirming the person signing is the client, appears competent, and is not under duress or coercion. D, confirming that the client voluntarily agreed to the procedure, is not being coerced. Documenting the client's questions and concerns and notifying the healthcare provider if needed. If the client has questions, the RN should document them and immediately notify the provider so they can return and address those concerns. A, ensuring the client understands the procedure. While the RN can provide clarification, it is ultimately the provider's responsibility. And in explaining the risks and benefits of the procedure to the client, this is not the RN's responsibility, it's the role of the provider. Answering questions about alternative treatments, again, defer these types of questions to the healthcare provider. It is their responsibility. So excellent job. You guys are so sharp. Does anybody want to read number 5? You guys need a break? A client scheduled for emergency surgery is unable to sign a consent form due to sedation from opioid administration. What should the nurse do first? A, obtain a court order for surgery. B, charge nurse to sign the consent immediately. C, obtain telephone consent from the family. Or D, take the client to surgery. What do you guys think?
C.
I think C.
D.
D.
I think D.
Client to the surgery.
I think D.
That is tough for
Because
me.
we don't have time. Because if the client is unable to sign, by the time something can arrive to the client, we don't have time to do that. We take the client to the surgery, and then maybe after that we will think about those things.
Okay, so
How about if something happened during the surgery and the family members say that the family members say, why do you sedate our patient without any concern?
Yeah, I could say C.
I
The
could say
consent from the
maybe we cannot.
family.
No, I'm just
Maybe.
discussing. Maybe I'm wrong, but I'm just saying if something happened during the after anesthesia or any.
So look at the
Because
question
it's
again. It says
I'm
it's an
just saying the
emergency.
Because
family
they
say
said emergency surgery.
It's an emergency.
Yeah.
If it's
Cannot have
emergency,
family on the
Can the
call.
professor explain to us?
Yes,
since
please.
it's emergency
the hardest part
situation,
on you, professor.
So this, I got to tell you, I read this one the first time when I was doing the presentation, and I was like, huh. And I picked C. So let's see. C is the right answer. I'm going to just go back to the options though, because I want to share a little bit here. Obviously, we don't have enough time to obtain a court order because in the patient's, it's an emergency, right? It tells us right in the question that it's an emergency. Charge nurses, they don't sign consents. So we know that one's not correct. And taking the client to surgery, we have to have some sort of consent. And sometimes it's implied consent, right? So if the family cannot be reached, somebody makes an effort, makes a phone call while somebody else is getting that patient off to surgery, right? Not starting, but getting them ready to go. And you can't reach the family, now you have implied consent and you take them to surgery because it is an emergency. It does say that it's an emergency here. So let's read the rationales because I think it'll help answer some more questions. In a situation where a client scheduled for emergency surgery in a situation, okay, I did read that right, is unable to sign a consent form due to sedation from opioid administration, the nurse must ensure that appropriate consent procedures are followed. Document all attempts to obtain consent, all those attempts to calling the family or their surrogate to get consent to take them to surgery. Make sure you're documenting all that because you're going to be using implied consent for this patient. So C, obtain telephone consent from the family in emergency situations where the delay to obtain consent would cause undue harm to the client. Verbal or telephone consent may be temporarily obtained that is valid for no more than 10 days. Verbal consent and the reason for verbal consent must be documented in the medical record. Okay? So
I'm
go ahead.
sorry.
No, don't.
Is the doctor can sign the consent form or not in emergency?
Well, they're not really supposed to sign. I don't think they sign the actual consent form.
Yeah.
But I think I have, and I don't know if it's appropriate or not. That's one of those things where you actually have to check your hospital policy because I have seen a physician sign across a consent form that they could not reach a family member. And it was, you know, it was an emergency. They had to take the patient to surgery. I don't know that that was legitimately our hospital policy, however, so make sure that you check your hospital policy. What I do know is that it needs to be documented. And if you're the person calling the family trying to get consent and you tried 5 times, make sure you're documenting 5 different times that you made that attempt, okay? And that no response was, you didn't reach anybody.
Thank you.
The key about this though is that you have to let the family or the patient, when the patient wakes up, know immediately. As soon as you can, as soon as you know the patient is no longer in harm's way, letting the family or the patient know that they had surgery is imperative, and making sure you document that as well in the medical record. Does that make sense to everybody? I'm going to go through the other rationales, but I just want to make sure you know that you do have to provide consent at some point, and it should be as soon as possible, as soon as the patient's no longer in harm's way. So obtaining a court order for surgery is a formal and legal approach typically used in situations where a client's consent cannot be obtained and surgery is not an emergency. So that's the key to that one. It's not an emergency. Charge nurse to sign the consent. The charge nurse is not authorized to sign a consent form on behalf of a client. Taking the client to surgery in an emergency when the client cannot provide consent and no family or legal representative or surrogate is available, implied consent allows for immediate life-saving surgery. However, the nurse's first step should be to make every effort to contact the family or legal representative before proceeding, and document. I can't say it enough. I can't say it loud enough. Document. Okay, so we had a lot of talking before with the questions. So did everybody's answers get addressed? Do you still have questions? Does anybody want to talk about it?
No, it's good. Thank you.
Okay. It gets messy. These are muddy. All right, number 6. Does somebody want to go ahead and read it?
The nurse is teaching a post-operative client about to use the compression cycles. Which instruction should the nurse include? Select all that apply. Avoid wrinkling when wearing compression cycles. Wear compression cycles throughout the day and the night. Ensure the cycles extend above the knee. Wear compression cycles immediately after waking up from bed. Remove cycling whenever swelling occurs for comfort. I will go A.
Okay, I'll give you a hint. There's 3.
And B, because it's still in the post-operative. Yeah, and the last one, I think it's D, but the right way it's before you waking up from the bed. Yeah, not after. Usually they say before, they say when you are in bed you have to wear the stockings, yeah? Or maybe now they say D.
Okay, so you said A, right? Did you say A?
I say A, B,
Okay.
and D. A, B, and D.
Okay, so A, the answer is A, C, and D.
Yes.
And we're going to go to the rationales. A, C, and D. So obviously avoiding wrinkles when wearing compression stockings. Wrinkles or folds can create pressure points. C, ensure the stockings extend above the knee. Compression stockings that extend above the knee are often recommended because they provide uniform compression. And then D, wear compression stockings immediately after waking up from bed. It's ideal to wear them as soon as a client gets out of bed, just like you said, in the morning before any swelling occurs. This helps prevent an accumulation of fluid and supports optimal circulation throughout the day. Now, B, wear compression stockings throughout the day and night. Are typically worn during the day to reduce swelling and improve circulation. However, they should usually be removed at night to allow the skin to breathe and prevent irritation. And then E, remove stockings whenever swelling occurs for comfort. It kind of defeats the purpose of using them. That one was a gimme, I think, right? Compression stockings are designed to reduce swelling and promote circulation. So good job, you guys. And excellent job reading. All right.
I have a question.
Yes. Is it about that question?
Yes, no, I got the answers right, but I've seen some people with compression socks that are not above the knee, and that's just the normal length.
Yeah.
I little disagree with that two statement, because before all literature they say you have to, before you get up, don't change the pressure in your lower extremity. You have to put the stockings next to your pillow and wear until you get up. It will be easy. That's the first. And the second one, as in other students say, usually they are hiring the stockings above the knee, no below, because they say if you have a popliteal cyst or anything in your popliteal area, you can have a whole day compression.
The other thing about, I have seen patients wearing them up to the knee. 99% of the time they're all the way up. But the times I've seen them just to the knee are the times when, you know how hard they are to get on, right? For whatever reason.
Guys, accept what NCLEX wants from us. Don't give
Yeah.
our opinion. Yes.
Yeah, and 99% of the time that's true. I have seen them up to the knee though for that reason, that the patients won't wear the other ones. Not in the hospital, but when they go home. So
thank you.
You're welcome. All right. Okay, if we move on then to number 7, are we good with number 6?
Yes.
Does anybody want to read number 7?
Nurse is teaching a post-operative client about the use of an incentive spirometer. The following statement by the client indicates the need for further teaching. I will hold my breath for 5 seconds and then exhale through pursed lips. I should exhale forcefully into the device to get the best result. I will take a deep breath in through the mouth and then hold my breath for a few seconds. I will repeat this process 10 times every hour. So basically, there is the patient, there is something wrong, and they have to teach the patient correctly. I understand the question like that. If that situation, then the B is correct answer, which is patient, there is something not correct. I have to choose not correct answer. So further teaching, that means I think is that D maybe. I will repeat this process 10 times every hour. It's, I think, too much in 1 hour 10 times.
Oh, it said choose it. It's true. I will repeat this process 10 times every hour. That's a true statement.
And then exhale
This is the
through
recommended.
pursed lips. I will take deep breaths in through the mouth in and hold my breath.
You have to inhale, not exhale.
Best.
So B, right? I should exhale.
Yes, B is the right answer.
It's one of those trick. It's not really a trick.
You're right. Exhale and inhale. Absolutely. I'm
But
sorry.
like your mind when you read it, your mind put the right word there, right? And
Yes, I was like thinking the big.
Yeah.
Oh my gosh.
For
Yes,
further
absolutely.
teaching.
Yeah. I did the
Thank
same
you.
thing.
Yeah, we are looking for the bad one.
Yes, but I was thinking like this is the correct answer because
Uh-huh.
I didn't recognize exhale. I like forcefully devise best result. Yes, that's the correct one. Oh my gosh. Thank you.
You're welcome. I did the exact same thing, and I got to tell you, there was a question in one of the presentations that I saw, and it said that the patient would have a normal vaginal cesarean delivery, and I scanned right over. I scanned right over it and went, "Wait, what did I just read? A normal vaginal cesarean delivery. The two don't go together. It's one or the other."
Yes.
Right? Right? But that was one of the options.
That's correct. Normal and maybe that's a new technique, normal cesarean vaginal.
Right, a normal vaginal cesarean. Wait a minute, wait. That's a trick. That's a trick right there. My mind read the right thing, but it really didn't say the right thing. All right, so B, I should exhale forcefully into the device. The incentive spirometer is used to encourage slow, deep inhalation, not exhalation. I will hold my breath for 5 seconds and then exhale through pursed lips. Holding your breath after inhalation helps reach the alveoli, promoting lung expansion. And I will take a deep breath in through the mouthpiece and then hold my breath for a few seconds. This is the proper technique, and that they will repeat it 10 times an hour. Using it 10 times an hour while awake is standard recommendation to help atelectasis and lung expansion after surgery. If only they would always do it 10 times an hour, they would do so much better. Sometimes it's hard to do though, because they've had surgery and they hurt. Okay, number 8, we're almost there. You guys somebody want to read it?
A nurse is performing a preoperative assignment for a client who is scheduled for a splenectomy in 2 hours. Which is the following statement by the client would be essential to follow up? I drank a cup of black coffee and ate 6 muffins 6 hours ago. I stopped taking an over-the-counter Estenia supplement 3 weeks ago. I developed redness and itching on my hand after eating kiwi 2 months ago. I had the autonomic emplacement cardiac defibrillator placed in my chest 2 years ago. I think it's a C because there's a kiwi allergy and the latex allergy.
That's right. Very good.
I think, because I have a question a couple months ago. Yes, because they say avocado, kiwi, some fruit and vegetable, which one allergen we have to compare to the latex allergy.
Mm-hmm. Anybody else have any thoughts? Okay. Remember I told you that they have this new guideline about, there's a new guideline on fasting. So I don't know what, your hospitals are doing, and you have to see what your hospitals are doing. Ours defaults to the 12 hours, but some hospitals are changing their protocol based on, whoever their anesthesiologists are, and they are changing it to a couple hours before.
That's why I want to say before they say at least it's supposed to be 12 hours and pure, yeah? Even they wanted the patient skip the medication or sip of the water. But now they say in the beginning, how I know this question, because in the beginning I pick up the A, be honest with you.
Mm-hmm. Yeah, well, and
because
honestly,
it's 6 hours, that's not enough, you know what, for the complication. Yeah, for the complication. And later when I read it, I don't know, as you say, each hospital is a different.
Yep.
But maybe over here, if they have aspiration, they can just, anesthesiologist can do anything. But if it's allergic reaction during the surgery, this one they can predict before.
Right.
Thank you.
You're welcome. All right, well, we'll take a quick look at the rationales and see what they say, though. I developed redness and itching on my hands after eating a kiwi. A history of itching and redness after kiwi may suggest a latex allergy. Kiwi, bananas, avocados are all associated with a cross reactivity to latex. So if the client has a confirmed latex allergy, latex-free equipment must be used during surgery. The other ones, I drank a cup of black coffee and ate a muffin. Preoperative fasting guidelines recommend avoiding solid foods for at least 6 to 8 hours and clear liquids for 2 hours before surgery to reduce the risk of aspiration during anesthesia. That's part of the new guideline that we're talking about. I stopped taking, I would be really surprised if you would run into them changing that on NCLEX. I can't swear to that, but just knowing that there is a new guideline out there it's good for you to know. I stopped taking an over-the-counter echinacea supplement 3 weeks ago. Echinacea primarily affects the immune system, not coagulation. And I had an automatic or an AICD placed in my chest 2 years ago. That's something that we should have known a long time ago. It's not new information, should already be in the client's medical record. It also, they do require special precautions during surgery, however, so it is important to know that. But I would assume that we know this before now. At least I sure hope we do. All right, number 9. Anybody up for it?
A nurse is caring for a client with a Jackson-Pratt drain. Which action should the nurse prioritize to prevent complications? Maintain drain patency, secure the drain, monitor the sign of infection, assess the drain site for bleeding. This one I can go for the infection. That is priority.
Okay.
C.
You say C?
Yeah, infection.
Anybody else got any ideas?
It's A.
I think it's A.
Yeah, A.
Think it's A too.
I also agree to the A.
I said prevent complications. So you have to
Yes.
monitor the sign of infection.
So
sometimes, guys, there is some question. Whenever we do them, even though we don't know what sometimes you are confused about, when you see patency, sometimes I see some question like that. Always 70% it's always patency, the answer.
Oh, the number.
Okay, let's go to rational. See what's going
Yeah.
on.
So when I look at this question, it says the nurse should prioritize to prevent a complication. So of these 4 things, what's going to prevent a complication?
To monitor the signs.
No, maintain the drain
Monitoring
patency
doesn't
to make sure
prevent
that
it,
everything is going well.
right? So if what's going to prevent it? There's maintaining
Maintain drain patency.
securing the
Make sure
drain,
that the drain is okay.
monitoring for the infection, or assessing the drain site for bleeding. Only one of those things will prevent complications,
I
right?
think D.
Assessment.
Or bleeding.
Okay, let's see what the answer is.
A.
Hey, I'm excited.
A, maintaining drain patency is essential to allow continuous drainage of fluid from the site. Regularly emptying helps ensure complications.
Oh.
I don't like to say the words trick question. However, when you read your questions, make sure you know exactly what they're asking for. And if you're looking to prevent something, that means we have to do something to prevent it. So when you look at those, only one thing does something, right? And that would be maintaining drain patency.
That's right.
In my
Because
mind,
this
that's
one-
how I look at it.
Yeah, because see, just you are monitoring, you don't do anything. That's
Right. Correct. We should be monitoring, right? It is a right answer, but it's not the priority.
Priority, yeah.
That's where they get you. All right. Last one, guys.
A nurse is providing pre-operative teaching to a client scheduled for surgery the next morning. Which statement by the client indicates a correct understanding of NPO instructions? I can have a light breakfast as long as I don't eat anything after 8. I can drink water up to 2 hours before my surgery. I should avoid eating or drinking anything starting at midnight before my surgery.
This is easy.
Yeah, to have a black coffee
That was very
for surgery
easy.
since it doesn't have a cream or sugar, so it's just C.
All right. Everybody saying C?
Yep.
Yay! I should avoid eating and drinking anything after midnight before my surgery. We really talked about the protocols now for fasting. So I would encourage you, though, just to find out what your hospital is doing if you don't know, because like I said, there are changes coming. They've been out there a while, so I would expect hospitals to, more hospitals to take up on them in the coming years. So to all of you, success is ahead. You guys are rock stars. I have to tell you, you guys are so smart. You You did a great job tonight. Thank you so very much for being here with me. And I again apologize in the beginning about the technical difficulties we had going on.
Thank you. Thank you so much. Yesterday,
Thank you so much, Professor. Thank you
yesterday,
very
they
much.
did before we don't have a classes.
Yes, you're
Thanks,
very,
we have today. Thank you so much.
you're welcome.
Thank
You
you
guys
so
have,
much.
I hope it was helpful to you.
It
And
helped a lot of, especially
Yes,
when it's
yes.
going to
It was
discussion.
really helpful. Really helpful. Yeah.
Professor, how often we will have it? Because we do not have any schedule. We don't know at what time we will meet. It's
say again.
Guys, we have a
every day
schedule.
or
Yeah, every day 7 to
Yeah, so if you
9
look at
and 9 to 11. Only once a while when we don't have a technical. Yeah.
or
Only
7?
we that. Yeah, oh yeah, only we don't have a connection once a while. The technical support can connect us as yesterday and the day before. So today
Oh.
only one class, but tomorrow 2 classes, 7 to 9 and 9 to 11.
Yep.
That's what schedule show, but let's see how they can connect us. Let us get there.
Yeah, you guys, good luck. And I know people have their tests coming up, so I just want to again wish you guys the best of luck. I know you guys will do great. Good work. Have a great night, okay? And I'll see
Thank you very
Thank
much.
you so
Thank
much.
you.
All right, good job, guys. Bye.
Thank you,
Bye-bye.
Prof. Bye.
Bye.
Guys, do you know where can I get the schedule? Hello?
You go to NCLEX, nclex.com.
Yeah, I think
It will
you
be
have
there.
to book for the class.
I think you have to log in first before you can see the schedule.
Yeah, when you log
Wait.
in, you see the classes and then you book for it, and then I think they'll send you a notification when the
Oh,
class is about to start.
okay. Otherwise, we will have the class every day.
I think they have all the dates on the dashboard of all the live classes.
Oh, okay.
So go to your dashboard and
Thank
then
you.
you can book for the classes. And if there's a live session, you would be notified.
Please, did anyone use this on her for her LPN?
No, I don't know. I have 2 days. Only 2 days. I didn't know. My friend told me about this
I think
side.
that they said that they have another one for LPN, but this one is specially for RN.
Yeah. We will have another class at 9 tonight.
No, today only one class.
Okay.